As we're having coffee and chatting, one of the extraordinary things about this gathering is these short presentations, and I appreciate that it makes things much harder for the presenters, but the rest of us get a very quick induction into years of work, for which we are very, very grateful, so thank you. The next session was to be facilitated by Niniqua Blanding, who is from the Boston Foundation. Niniqua unfortunately had a death in the family yesterday, and so she sends her regrets, and she cannot be with us. So I've asked David to facilitate the next session. David.
In this next session is methods and approaches to understanding health in cities through the lenses of other disciplines. And I have a series of speakers here, and we're going to start out with Richard Rodger on history, please.
Well, thank you very much for this opportunity, and to the organizers. And I'm in a very fortunate position as a historian, economic historian, of knowing how the game ends, because you've told me, so there's not a lot to say, really. Well, that's actually my message, because the continuities are really important. I have 5 continuities I'd like to stress right at the outset in just a couple of examples. One of them is about the real importance of local government administration, and we heard a bit about that earlier, about the willingness to develop an alliance of interests to forge a sensible, livable city. A second one is about the composition of employment. We heard about that too. So it's clear from the very long run of history that where we have essentially professional or a middle class or a skilled artisanal or a manual labor domination or a balance thereof, fundamentally affects the kinds of things we're talking about, the health and wealth of nations. And that parallelism I allied throughout the work that I do. The technological innovation has been another factor throughout. I'll show you a slide in a moment. I might as well do it now. Here's a slide that shows town foundations over the very long span east of the River Elbe in Germany now. And it shows a really active period town foundation. Why do people want that? Why do towns found things to get charters, powers, monopoly rights, and so forth? Because it conveys those advantages, those economies of scales, the concentrations of skills that we heard about in the previous session. But the failure of town foundation in that part of Eastern Germany and Eastern Europe as a result of the Black Death shows the volatility of the system, that increasingly a reversion to agricultural or small towns did not have the same kind of presence in terms of town administration. So composition of employment, technological change, ability to construct an effective public administration, all of these things impacting on social and environmental justice or injustice. But tax incentives might be a way forward, because that's really what these town foundations wanted. The right to raise tax and administer that tax in manners which were usually agreed, but not necessarily agreed, by the city fathers. So the tax dimension to this, I think, is really crucial, and we've not heard much about that. And the final thing is about the jurisdictional aspect of this. So I give you a couple of little examples, glimpses of this. In Linköping, in Sweden, there was a squatter settlement in the east of the city. They wanted to be part of the city. And the trouble was that the town charters, even into the late 19th century, excluded the extension of the jurisdiction into that area. End of story. 30, 40 years go by before anything happens. Squatter community permanently residing on the outskirts of this city. Take it the other way round. In Berlin, at the same time, there was an ordinance which said you must have toilets, WCs, in the tenements, the Mietskaserne of Berlin. Well, that forced up rents. It forced people out of their houses. They founded squatter communities in Brandenburg outside the boundaries of the city, where squalid housing was much worse than when it was actually when they actually lived within the city. So the ordinance here has achieved completely the reverse of its intention. I studied a medical officer of health who actually was having a very fruitful dialogue with Lemel Shattuck here in Boston in the 1860s. And he absolutely, his name's Little John, he absolutely refused to introduce water closets into Edinburgh. And the reason was simple. The hydraulic engineering simply did not allow for it. It's simply, in a hilly city, forcing pressure to such a level to allow a distribution of water was not possible. So it seems a counterintuitive decision to take, but nonetheless, here's a technological solution in waiting with the hydraulic engineering. So for me, this trio is crucial, and I think it's been the same throughout what we've said so far today. That absolutely, it depends if you have continuity of employment, if you have a certain class of job that's not susceptible to casualization, then you're in a really strong position in terms of your patterns of consumption, the quality of the housing, how your nutritional standards allow you to beat off the disease. Find yourself out of work, poverty, the health goes down, the ability to work in the market is much reduced. And so this vicious triangle reinforces the social and environmental injustices that existed in our cities, and I think still does. This is Edinburgh in 1860, and this is the book I'm donating to Boston University Library, and this was Little John, the man I referred to a moment ago. So this is a report written in the 1860s. Now, long before this, Johann Peter Frank in Germany wrote 9 volumes about medical jurisprudence based on public administration and meticulous research. And the French hygienists did exactly the same 20, 30 years later. But for the most part, Little John goes far beyond the areas that we would normally accept. This is a tabular account of his report. And it shows focus on occupational disease, a focus on food quality, a focus on all these sorts of other aspects, and not just on drains and sewers. The integrated, holistic nature of the medical jurisprudence, which is a critical part of Scottish medical training. Every doctor had to do medical jurisprudence course and had to serve in a public dispensary. They knew what poverty was. They knew that it was not, it was an exclusive matter for some of the rich. So here's the conclusion, in a sense, for me. A rising, jagged line of revenue over the very long period, from 1875 down to 1920, and a rising level of spending on a whole variety of different topics, which included not just the ones I've mentioned, but vaccination, compulsory notification of diseases, food adulteration, public labs, tighter regulation of markets and slaughterhouses, and as the 19th century drew to a close, far more emphasis on child and mother, and the provision of school milk, medical inspections at school, and so on and so forth. So social insurance, in a sense, was a logical succession to this kind of holistic approach, and was introduced in Germany in the 1880s and in other European countries before the First World War. This is the safety net that the state was prepared to provide when the market failed persistently, and it allowed many to endure in difficult circumstances, the market circumstances which were so punitive in a cyclical way in the period before the First World War. So those were my 5 points of social and economic and cultural inequalities, which I see coming through from a period over many centuries, and which does not leave me too negative. I think there are good reasons to believe that the difficulties we've heard about are not inescapable. Thank you.
Our next speaker is Danny Ompad from NYU, please.
Slightly shorter. Good morning. So I am going to be talking about a system science approach to urban health. And I would like to thank David and Sandro and Catherine and your entire team for organizing this conference. I think this is a really important topic. So I thought I would start by talking a little bit about complexity. So the first 2 sessions we had this morning, if you take each topic on its own, they're complex, but when you put them all together, it's a little overwhelming. And so I don't know if you've ever seen this. This is the conceptual framework for urban health that was developed by Sandro, David, and Nick Freudenberg. And it kind of outlines, I would say, a lot of variables at different levels to describe what's going on in urban settings. And, you know, when we think about systems, there's not really one definition of what a system is. Some scholars define systems very generally, such as a set of objects together with relationships between the objects and between their attributes, while others see systems as evolving and complex, with many components that adapt and learn as they interact. So about 10 years ago, I went to a meeting in Vienna with the ICSU, which is an international scientific union, and I started hanging out a little bit with some system scientists. And when I spoke with them, I had this conceptual framework in mind, and I was like, oh wow, this is so exciting. We can model this whole thing. We can have one for every city and try to understand how cities work. And so the system scientists quickly disabused me of that notion. It's not possible, at least in 2018, to model the whole system, and you probably don't want to model the whole system. And so then when I moved to NYU, a colleague came to join us. Her name is Yeshim Tozan, and she is the co-author on our chapter. And she's a health economist, but she was trained in systems dynamics. And so over many conversations, she kind of explained to me how systems dynamics works, where you take one problem and you try to figure out what are the critical elements of that problem and put that into a systems model. It's often built with a community of scholars, or even the community at large. And what I came to understand is what I had been taught in epidemiology, and most of us have been taught in biostatistics, those types of models are not able to really unpack this complexity, right? And in an age where people talk in sound bites, like the epi models are really nice, I give you an odds ratio, maybe you can understand what the odds ratio is, you know, one group is 2 times as likely to have an outcome if they have the exposure, but that's not quite what we need to do in cities. We really need to understand how all the elements of the cities that are important to a particular problem interact with each other. And the systems approach is particularly relevant when you're thinking about policy interventions, right? So one of the things I thought about when I was thinking about systems is what happened in New York with the tobacco interventions that they did. So New York City decided that they were going to raise tobacco taxes, so now it's about $16 for 1 pack of cigarettes. They provided free patches, there was counseling, and they had eliminated smoking in public settings. And so that was really great, and overall, smoking rates in the city went down. But at the time that they were implementing these interventions, we actually had offices in Harlem. And so I would walk from my house in East Harlem to Central Harlem to go to work, and there would be dudes on the corner selling Newports for $5. Right? And so what happened was an unintended consequence in that there was a development of a black market in cigarettes that didn't have the New York state tax stamp, and they were sold for cheaper, right? And so this is something that we might have been able to predict had we kind of thought about the types of things that would happen with these policies. And so systems approaches are very helpful in addressing these types of issues and helping us predict the potential consequences or the feedback loops, right? So epi methods don't really deal with feedback loops. And so when we think about systems approaches to public health, we can think about three main types of methods: systems dynamics, agent-based modeling, which is really hot right now, and something that we've been doing for years, which is social networks or network analyses, right? And so in the chapter, we kind of go through some examples of these. Systems dynamics is not as widely used in public health, although it's becoming more common. And one of the examples that we came across was an example looking at bicycle policy in New Zealand. And they basically built system dynamics models with scholars and with people from the community to understand what types of bicycling policies would best fit the situation in that city. When we looked at agent-based modeling, which if any of you have ever played Nintendo Wii, I think of the little Miis that you develop that are kind of like your avatar. So to me, agent-based modeling is basically a bunch of avatars that have been programmed to behave like humans, although we can argue whether or not we can really capture all of human behavior in a model. But what they basically do is they program the avatars or the agents to behave in certain ways, and then they introduce different things into the system to see how those agents react. And so what they modeled in the example we presented in the chapter was fruit and vegetable intake, and whether or not changes in policies like an increase in the number of green carts or the increase in subsidies for fruits and vegetables made a difference in intake. And they did, and the more you subsidized and the more you made it available, the more people were likely to partake. So I will close with disabusing you of my fantasy that we could have one model to rule them all. I don't think that's possible right now, but I do think that these systems approaches can really help us be strategic about thinking about the types of policies we can implement, as well as the potential consequences of those policies, whether that's good or bad. So thank you.
And our next speaker is Michael Gusmano, right here.
Well, thank you very much. It's a pleasure to be here. I want to thank David and Sandro, my old colleagues from the New York Academy of Medicine, for inviting me to be here today and contribute to the discussion. I'm going to shift gears a little bit, although there will be a lot of overlap with some of the things we heard earlier, particularly around inequalities and multiple sector research. Outcomes, but we heard about sort of the mega trends of urbanization and population aging, and one of the other mega trends is obviously increased spending on healthcare services and the sort of extraordinary development of healthcare technologies. And if you put these together, it turns out there's a lot of healthcare being delivered in cities, even though we all know that social and economic determinants are far more important to health than healthcare. Healthcare matters when you get sick. And so there has been a kind of growing effort, I would argue, among researchers and in the literature to understand how city health systems actually work. There's a fairly long history of looking at academic medical centers and other parts of healthcare safety nets, which are often concentrated in urban areas. There have been efforts to look at particular populations. Many of us care about health inequalities. We're worried about what happens to poor and other vulnerable groups, and they are often concentrated in cities, and that drives some of the research as well. More recently, you started to see people looking at entire healthcare systems. We just heard a talk about systems research and complexity, and I'll get into that in a moment. So what we've been trying to do in my research is to compare health systems around the world, in particular look at cities that have a lot in common. They're all large. They have diverse populations, but they exist within national health policy contexts which are radically different, to try to understand how those macro level policies may influence the way health systems work at the local level. But of course, one of the big challenges you have is how do you actually figure out the difference the health system is making? How do you disentangle the effects of health care and its use from all of the other factors? This is difficult regardless of your level of inquiry, and at the city level, it's particularly challenging. In fact, one might wonder why I've spent 20 years trying to do this, given the difficulty of doing it, because the data often don't exist to allow you to do it. So we've been playing around and trying to figure out how we can use metrics that say something about the impact of healthcare on outcomes and that are available at the city level, preferably, whenever possible, at the neighborhood level, defined in various ways. The other green button. So one of the factors we've used is to look at something called amenable mortality. It was an idea established actually in the US in around the 1970s, and then really picked up steam, I think, mostly among European researchers, and now it's more broadly used. The idea is to use death records, which are highly imperfect. We could talk for a very long time about their imperfection, but are widely available. And to look at subsets of deaths, not just all premature death, which can be influenced by a range of factors, but to try to look at causes of death for which there actually are effective medical treatments. And it's a longer list than this. Some things can be eliminated completely. We should be able to get maternal death down to 0. We don't always, but we should be able to. Tuberculosis, we should be able to drive down, not just through medical care, but in part through medical care. And then there are a number of cancers where you can really drive down the rates. You're not likely to get them down to 0, but if you have better access to effective medical treatments, you would hope to drive them down. And so we've been looking at this for quite a while. We started out looking at big cities in the OECD, New York, London, Paris, and Tokyo, and more recently have started looking at cities in the so-called BRIC nations, Brazil, Russia, India, China. We haven't gotten to South Africa yet. So here are some data going back between the first decade or so of the 21st century. And what's really remarkable about this slide is the incredible decreases that we have seen in amenable mortality in all of these cities, both in these rich countries and middle-income countries as well. London came down the most, actually. They fell between 2000 and 2010. They dropped by 42%. So all of Tony Blair's additional spending in the late 1990s in the NHS may have paid off in interesting ways. But the aggregate decline is only part of the story. We're interested in inequities within the city. And it's very hard to get at this, but we've been able to look essentially at postal codes. And you see a fascinating pattern. We started with, again, New York, London, Paris, and Tokyo, where we compared the people living in the lowest income neighborhoods of those cities with people living in the rest of the city to see if there was a difference in rates of amenable death. And it turns out there was in New York, and there still is in New York, and it's quite stark, and it's consistent, and it's the same neighborhoods over time. We don't see this pattern in any of the other cities that we've looked at within the OECD. When we turn our attention to the middle income nations, we do see this pattern quite starkly, particularly in Sao Paulo, although I think we would see it in bigger ways in the other cities that we examine if we actually had better data. There is an exception to the overall pattern, and this is in New Delhi. We had to use a slightly different definition because they aggregate everyone over the age of 70 in the census, so our denominator's a little bit different. But we looked over about the same time period at amenable death within New Delhi. And there are three things. First thing to say is you'll notice the arrow's pointing in the other direction. Rather than these massive declines, we're actually seeing fairly massive increases, about 25% increase during a time when the Indian government and where the New Delhi government was pouring a lot more money into their healthcare system, trying to expand access to drugs and trying to improve the quality of the healthcare system. Second thing to say is we almost didn't get this published because it turns out that there are a large portion of deaths that are not medically certified in India. A doctor never checks off cause of death, and it turns out to use this, you need cause of death. We got it published because the rates of medically certified deaths are 17% in India as a whole, but they're 66% in New Delhi. So I convinced reviewers that 2/3 wasn't bad, in relatively speaking. It's still highly problematic, and it means that these numbers are likely actually much larger for the city because, of course, the people for whom there are no medically certified deaths are those who are living in the slums of New Delhi, are less likely to receive adequate medical care. Again, like these other cities, we see big gaps within the city, enormous gaps. Furthermore, New Delhi stands out because in all of the other BRIC cities that we looked at, tuberculosis, sepsis were high in the top 10 causes of amenable mortality at the beginning of the decade and fell out of the top 10. And these causes actually increased in New Delhi, pointing to a sort of a complex array of social and environmental factors, but also problems with the healthcare system. With regard to TB, I think it's both the overuse and the underuse of antibiotics that's likely behind this. You have an underuse when people get sick with TB, they're not adequately treated, but because you have such an overuse and unregulated use of antibiotics throughout the country, you're also seeing the rise of antimicrobial resistant tuberculosis. So these data are not sufficient. I think you need mixed methods to go in and speak with people, which is what we have found over the years to really unpack the causal stories, but they're useful in terms of tracking trends over time. So I'm going to show you one more. This is a little case study. It's like the New York City case study panel. We have also looked at something called hospitalizations for ambulatory care sensitive conditions or avoidable hospitalizations. And these are conditions that can be treated outside the hospital, and if people have timely and appropriate access, they shouldn't end up with an inpatient stay in the hospital, most of the time. I'm just looking at Manhattan, where we had someone from the Bloomberg Foundation before. This is effectively bookending Mayor Bloomberg's term in office when there was a great deal of emphasis on health, public health, and health care. And you see that Manhattan had a remarkable track record of driving down rates of avoidable hospitalizations. There was a much greater effort to get people into primary care, to get people into ambulatory care, and it resulted in a reduction in hospitalization. And that's the happy part of the story. The more challenging part of the story is shown when we started doing some of our regression analysis to understand differences within the city. This is looking at insurance, and we look at a variety of both individual and neighborhood level factors that might explain differences in avoidable hospitalization. By insurance rates, what you see in blue are the odds ratios from the earlier period, 1999 through 2000, and on the right-hand side in red from 11 to 13. And what you see is that people without insurance, people on public insurance compared with those with private insurance, are far more likely to end up in the hospital with one of these conditions. and the differences haven't really changed much over time. Holding insurance constant, though, we see, not surprisingly, very large differences by race and ethnicity within the city. We have driven some of the differences down with regard to Latinos. So the rates among Latinos appear to be lower. In fact, they're lower for everyone, but the odds ratios, the differences between blacks and whites within the city with regard to avoidable hospitalizations are just as large now as they were at the beginning of the decade. So as you can tell from looking at these data, these are fairly crude. They're fairly high level. We're able to leverage them, and the nice thing about these kinds of indicators and this sort of data is it allows you to say something about what's happening within the healthcare system over time. They're publicly available. They're collected fairly routinely. And that allows us and they're also coded in more or less the same way, which is quite powerful when you're trying to do comparative city research. Unfortunately, they leave a lot to be desired. Right? They tell you very simple things about individuals. They can be linked ecologically with the neighborhoods in which you live, but there's much that we don't understand about what's going on. And one of the big challenges as we sort of moving our research from cities in the richest countries in the world to low and middle income cities is that we're really often limited when we're not doing original data collection and interviews to using death data, which are quite crude. Most of the hospital systems in China, for example, we haven't been able to use this because they actually have invested quite a bit in collecting hospital data, but when they collect the data, they don't actually collect data about where the person lives. So when they have an address on the record in hospitals, they include the address of the hospital. So I can do a fascinating hospital study, but I can't say anything about where people live and how those environmental factors might be influencing their health and their use of healthcare services. So that's our big challenge. Thank you very much.
And our last speaker for the session is Guia Guffanti. Please come.
Thank you. Good morning. I want to start by thanking the organizers and Team Galea for the opportunity to present and write the chapter on cells to society approaches. My name is Guia Guffanti. I am a statistical geneticist. I am a faculty at Harvard Medical School. I work at McLean Hospital, where I lead the effort on computational genomics approach, and in particular in the field of anxiety disorders. So I'm going to give you hopefully an overview of what can be found in the chapter entitled Cells to Society. And my focus was on the challenges that living in cities implies for the health of the individuals and their communities, and ultimately how Cells to Society's approach can help understanding the health of urban populations. As human beings, we are a product of our genetic makeup and the environmental surroundings. And the question is how the social and physical environment can influence, if at all, the individual biology, and ultimately how urban stress can get under the skin. The technological advances in the field of biology in the past few decades have been incredible and have led to an unprecedented opportunity to really investigate this issue at a scale that was not possible to imagine before. And so thinking about environmental exposures, obviously I do not want to reiterate on this. We had beautiful presentations. So in the context of these cells to society approaches, we think of nutrition, exposure to chemical compounds, physical exercise, physical and psychological stress, trauma, and many other factors that can affect the way genes, DNA sequences, are ultimately expressed into proteins. And the discipline that seeks to identify the mechanisms that basically lead this possibility of the environment to influence and to alter the function of the genes is called epigenetics. This emerging branch of biomedical science attempts to answer the question of how the exposure stimuli may induce enduring alterations that were not genetically programmed. And that's the most exciting part, I think, of the whole story. Such modification arise at the molecular level without changing the genetic code. And as I will hopefully be able to tell you in a few minutes, something even more interesting is that these changes are potentially reversible, so actionable in terms of prevention and cure of diseases. And as I was mentioning before, these new technologies now give us the opportunity to go and really assess and quantify them, to quantify the effect of the environment on biology. One of the key features emerging from the recent studies is that environmental changes have the potential to modulate biology not just at one single time, but they can have an effect throughout the lifespan. And that also is related to another interesting topic, which is related to the sensitive periods. There are definitely certain specific times during the lifespan that can be more sensitive in terms of these changes. For example, the environmental exposure that occurs early in our lives during embryonic development or early in the postnatal period has the potential to mold our future growth and change how we respond to the environment or our susceptibility to disease later in life. And there is a growing body of evidence that has shown that an association between exposure to environmental changes early in life and the origin of late onset diseases, including metabolic, immune, cardiovascular, and behavioral complex disorders. Although the epigenome seems to be mainly receptive in these particular phases during early development, let's not forget that it's still a plastic entity, and as such, its plasticity persists throughout the entire life course. And it can even leave a lasting signature because it has the possibility to be inherited from one generation to another. The mechanisms that mediate epigenetic regulation include DNA methylation, which is probably the one that has been studied the most, and other post-translational modification of histones, chromatin remodeling, and the regulation of non-coding RNAs. I'm trying not to give a full biology class here, but just to mention that these are all the potential mechanisms that are implicated and that we have now the ability to assess and quantify. In particular, I want to highlight this feature because I think it's very remarkable and it will be very interesting for the few years to come, is that of all our genome, only 2% is really producing proteins, what we are probably more often thinking about when we think of genes and DNA. The remaining 98% has not even been completely studied, and there are features that have not been yet identified. So there is a huge amount of information that is lying out there and is now being accessible for us to investigate. And I'm particularly focusing on non-coding RNA's work because they seem to have this potential to be activated and reactivated in their functions, especially after exposure to specific environments. So I mentioned the environmental factors, thinking about the studies that have been produced so far in the field of epigenetics and environmental exposure. Physical factors can include chemical pollution, noise pollution, artificial light pollution, infectious diseases, and diet quality, but also there have been studies that consider social factors, including, for example, concentrated disadvantage, racial segregation, dilapidated built environment, and of course, crime. All of these factors are associated with some form of physiological, think of oxidative stress, and psychological stress. An example, exposure to environmental pollutants hazardous to human health is among the most critical risk factor in urban settings for the development of adult onset pathologies such as asthma and other allergic conditions later in life. And these contaminants can cross the placenta during pregnancy and induce epigenetic alteration that alter the course of healthy development and set the stage for disease pathogenesis. Exposure to heavy metals such as cadmium early in life leads to epigenetic alteration that may persist over time into adulthood, leading to a higher risk of developing cardiovascular diseases. Poverty, which is most frequent obviously in urban settings than in rural areas, brings with it different stressors, physical stressors, such as unhealthy diet habits, and we heard about it, and social, such as increased prevalence of smoking. And there have been studies showing that African American boys who grow up in highly disadvantaged environments display shorter telomeres, another feature of epigenetic machinery, than boys who grow up in highly disadvantaged environments. Last, probably for lack of time, it's a cumulative life stress that was found to be associated with accelerated aging in urban population of African American living in Atlanta. And this has been associated obviously with developing aging-related diseases such as coronary artery disease, arteriosclerosis, leukemias. And forms of stress exposure exacerbated in the urban settings include also racial discrimination and segregation, and influencing DNA methylation. So far I kind of reviewed and all the possible negative aspect of epigenetics and environmental exposure. I just want to end on a more positive note, just to say that exactly because of this plasticity, we can also think of all the adaptive and coping mechanisms that we have available through epigenetics. And there is one very interesting example of a research that revealed that a father's diet could influence the adaptation of his child to be better suited to the dietary conditions that he lived in by transmitting epigenetic changes affecting the digestive system of the child himself. So there is hope, I think, and that's exactly why we need more studies now that biology is ready, more integration, more multidisciplinary studies to be able to consider the global effect of environment on the biology of human beings in urban settings.
If the panel could come up, please. If the panel could come forward, we'll have just about 10 minutes for some questions. Is that right? Okay. So it's an opportunity for some questions. I'm looking around the room for a hand or two. I was particularly impressed with the last talk and the idea that cities can get under your skin, right? So very important, and a lot of work that needs to be done in this area. A small question, and that is, I was looking at the map of over time in Berlin, and there was the Black Death, and after that the number of cities went down. But actually the number of cities decreased in two time periods before then. Was that anticipatory or coincidental? What do we know about that?
We only know that, which periods are you talking about?
It's the It's the figure that you had
Yeah, it goes
that
to-
had the number of cities, and there was a spike going up, and then it came down. It looked like 20, maybe even as much as 40 years before the era of the Black Death.
Yes. There were a number of different phases of the Black Death and other plagues. And in fact, if we look at that across Europe, the individual cities have quite a different pattern. As you can imagine, for example, in one place in England, there were no survivors. The overall average was somewhere between 20 and 40%, and it was not unusual to be 60%. So there were significant variations from place to place. I've averaged them together here to give the overall impression. I think what is interesting is that it also has a Soviet dimension to it, that particular graph,
Right.
the Soviet era, where actually the town foundations do not increase for some time.
Very good. So we should be thinking more of a confidence interval rather than a point estimate on that figure, just to put it in epidemiologic terms, I guess. Agus, please, and a microphone.
I was really fascinated by your presentation on epigenetics. I wanted to know, how much do we know about variation, individual variation to the same exposures, environmental, social, and so on? I mean, to be able to use this in terms of a population approach, I wonder what is it that we should also know to maybe protect some, maybe have individualized measures for different, because I can see this as another dimension of inequalities.
Absolutely, and this is probably one of the major struggles in the field of genomics, I think, nowadays, because to kind of facilitate the approach for the complexity from the environmental side and genomic side, the effort is always toward trying to maximize and kind of dilute the differential expression of individuals. And we definitely have to go back to an approach that is looking more at the individual rather than the big group. So especially for this type of studies, the ones that I was able to review in the chapter, it seems like we are still already in a phase where we are still struggling to be able to collect enough information to conduct the studies to compare groups. And I think that even if you can find these very small studies and it's already a huge kind of information, like for example, to study the effect of segregation and racial discrimination, that was definitely something that has to convince, I think, both fields to be able to actually put efforts into doing that. On the specific question and topic of how we can include the individual dimension, there is some hope that is also coming from another incredible advance that has been, that is just not looking at tissues, but is looking at single cells, and that is kind of, from the point of view of genomics, focusing more on the individual, and that is possibly one of the way that we can think of this moving forward, but it's definitely something that we have to work on more.
I see we have one in Carla?
Thank you. It's a question on history. You cover long-term trends, centuries, last century, previous century. I think that my impression is that the recent history of policymaking and what worked and didn't work in the attempts of a city to get better do influence a lot the kinds of decisions which I take in the immediate future. How much work is there in that, and how can you equip people in the urban level to get hold of that kind of information to be able to understand better the opportunities for policymaking in urban areas?
Thank you. It was really for the purposes of today and for the volume that I had this long-range, long-term interest to present today. But there is a huge amount of material, public health material. What does it contribute? Well, we have data sets, huge data sets across many countries. Not just the death rates that we were hearing about at one stage, which are certainly very vulnerable at times, but we have a lot of specific data on individual conditions. So let me give you a specific example. By mid-century in British cities, and certainly by, I would say, 1880 in all British cities, there were detailed records about the incidence of rates of a range of diseases. I mean, there are tables of 40 or 50 different kinds of diseases. So we get the incidence, and we also get in the denominator, we're also getting the overall population in districts. So this man, Littlejohn, set a standard of statistical analysis, which I think was exemplary at the time. If I could just explain that, he took the deaths across a city of 160,000 and reclassified every single one of them from the official registration districts into something which we would now perhaps call natural neighborhoods. So he's got to take a data set, some of which is at a very, very detailed level. And I think we calculated this at one point. There's something like 2 million calculations involved in undertaking this reassignment of the individual deaths by these new areas. 19 different sanitary districts were identified. Now, that was fairly typical by the end of the century. It was innovative at the time. I don't think there's any parallel anywhere that I know of that was the same degree of depth. And then these were, in effect, mapped. So we can say, down to individual areas, 19 after all in 1860, quite precise areas, we can say exactly what sort of problems there were. And he identifies 4 particular areas where the level of death rates and incidence of different diseases is very precise. It's down, I mean, he works to 2 decimal points, long before we had an Excel spreadsheet, and certainly no, well, he probably used logs all the time, actually, to do this. So there's a massive statistical movement in Europe generally, in Britain in particular, which develops from the 1830s and 40s, and it develops specifically because the cities have new powers at this time to assemble new departments and to finance these departments of the cities so that they have a massively extended statistical basis for judgments. Now, it's that degree of precision which I think was carried forward to enable various other developments to take place. So I just, for your patience, this procedure then identifies where the incidence of different diseases are greatest, leading to the introduction of social insurance in 1908 and 1911 in the UK, 1883 in Germany, where there were similar detailed studies available through public health analysts. I think there's a statistical revolution that has taken place in mid-century to provide a real understanding of how health and wealth were connected. And that's really what that book was largely trying to do, to show precisely how policy was defined by statistical methods which were robust and extensive.
Very good. This session, I'm afraid, has come to a conclusion. I know there are additional questions, and we'll just have to bring those up with speakers in the next section. So thank you very much. Let's show our appreciation.
Thank you, everybody. I'm going to roll us right into our next session, which is also our last session before lunch. This session is about approaches to urban health science. It's going to be moderated by Jalone White Newsome, who's a senior program officer at the Kresge Foundation. Jalone.